Hey everyone, and welcome to our next lesson in the trauma series. Today, we are going to talk about crush injuries. So, as you can guess from the name, a crush injury is pretty bad. Now, seeing as how the human body is a pretty fragile thing, you put enough force upon it, and bad things are going to be expected. When we talk about crush injuries, we're talking about a part of the body that gets caught between two objects. Now, this is different from like a blunt force trauma, where the impact usually comes from one side. Crush injuries occur in cases like motor vehicle collisions, where the patient's crushed between the seat and the steering wheel, or like when someone is run over, they get crushed, between the tire and the street. This can also happen when something falls on somebody, when they get caught under something. Think of like a bookcase falling over and landing on top of someone. How about if a roof beam falls at a construction site? Maybe you're even working on a car and the jack falls, like our friend in this picture right here. Now, by the way, that is one of my biggest fears. I mean, have you seen the jacks they include with cars these days? I get terrified every time I have to change a flat, but I digress. So I want to talk about some major complications when it comes to crush. Yes, the fact that a part of the body is crushed can never be a good thing, but it's the cascade of events that occurs after that initial injury that's really the more worrisome part. So some of these complications are compartment syndrome, traumatic rhabdomyolysis, which we're just going to call rhabdo because it's a really big word and I just like rhabdo better, hyperkalemia, and metabolic acidosis. If you guys want some more information on rhabdo or metabolic acidosis, there are some great lessons on NRSNG and some of our other units. They really explain it well, and if you just add a traumatic scenario to them, you'll kind of understand how it applies here. So compartment syndrome. Compartment syndrome is a buildup of pressure in the fascial compartment. As the pressure increases, it starts to cut off blood flow, and it can eventually lead to nerve damage and muscle and tissue death. The most common site for compartment syndrome are the lower leg and the forearm. Now, the amount of damage that occurs is really dependent on the time that the pressure in the compartment continues to build. So when it comes to assessing compartment syndrome, we want to look for the 5 Ps. Pain, and it's pain that is out of proportion to the injury. So if the guy has a small bump on his arm, but he's screaming bloody murder, that's a red flag. Second P is pressure. So the compartment or the extremity is going to feel tight when you press against it. The skin's also going to appear a little more taut than usual. Again, red flag. Pallor, right? As the blood flow is compromised, that skin color and the temperature is going to start to decrease. Red flag. Fifth P is paresthesias or paralysis. Paralysis or paresthesias. As the nerves are compressed by that increasing fluid, numbness, tingling, loss of sensation, and eventually paralysis can occur. Red flag. And our final is pulses, right? So as that pressure increases and starts to cut off the blood supply, we're going to lose pulses distal to the injury. This is a major red flag. So if we suspect compartment syndrome, we want to measure the actual pressure in the compartment. And to do that, we use a device with a manometer attached to us to tell us the pressure. Manometer. Now, one of these things, one of the very common devices is something called the Stryker needle, Stryker needle. Google it, and you'll find a lot of pictures about the Stryker needle. Now, I've worked in several trauma centers, and the Stryker needle is always there. Your facility may use a different brand of device than the Stryker needle. It might be called something else, but the purpose is always the same. We want to make sure that the pressure reading is less than 30. Normal readings on the manometer are 0 to 8. 30 to 40 usually indicates ischemia. So the treatment of compartment syndrome, if we're getting those like 30 to 40 readings with the meter, is usually a procedure called a fasciotomy. That's when an incision is made through the skin all the way down to the compartment to relieve the pressure, many times done right in the ER. It's not that wound isn't closed right away because you want to let that pressure decrease. And if you closed it up right away, the pressure would continue to build. Many fasciotomy cases, like the one over here in our picture, require some skin grafts. This guy's already been grafted. You can kind of see the mesh in here. That guy's already had one skin graft. The reason being is you can't really close this. Once you've left that open, you can't really close it with simple sutures. These up here, these are retaining sutures. Those aren't like closing sutures. When we talk about rhabdo, there are a number of things that can cause it. So there's a great lesson, like I said, on NRSNG in the musculoskeletal section. Check that out if you want to learn more. Today, we're just going to talk about rhabdo that follows trauma. So rhabdo is caused when the stuff that's in the cell leaks into the bloodstream, and it's usually because the cells are broken or basically just exploded. Just think of the trauma that caused it. So one of the big byproducts of this destruction is the release of something called myoglobin. Now, myoglobin is excreted by the kidneys, but too much of it, and the kidneys start to die. The myoglobin causes a decreased flow of oxygen to the kidneys when there's too much of it, and the end result is renal failure. So one of the textbook signs of rhabdo is really dark or absent urine. And I'm going to talk a little bit more about myoglobin on the next slide. So with the kidneys shutting down, the body can't process those toxins, and they start to build up in the bloodstream. Another result of this is acute confusion. The toxins build up, they go to the brain, more confusion. So in a trauma patient, we got to kind of put a puzzle together. Dark urine, acute confusion, traumatic crush injury, must be rhabdo. So how do we treat this? Well, we need to flush out the toxins and get those kidneys clean. Normal saline to the rescue. Throw in 2 large bore IVs, open them wide, get several liters going. We want to increase urinary output. We want to improve mental status. And if we monitor both of these things, it's going to give us a really good idea if the treatment is effective. So when it comes to metabolic acidosis in trauma, again, it's usually because something's leaking. Like think of a tomato or an orange. If we squeeze it, it leaks, right? That's kind of the same thing here, but instead of disgusting tomato guts, the body's leaking things like lactic acid, potassium, and myoglobin. Get it? OMG, myoglobin. Sorry, guys. Anyway, so when we have hypoperfusion, decreased perfusion, and in this case, it's because the tissue is being compressed from our crush, the cells start to produce lactic acid as a byproduct of the anaerobic metabolism, and the body becomes acidotic. Again, NRSNG has the great lesson on acidosis. We're just covering the basics as it relates to trauma. So the cell destruction also releases myoglobin, like we talked about in the last cell, and the presence of that myoglobin can sometimes help us diagnose as it turns the urine that dark brown. So if you see that your multi-trauma guy is peeing something that looks like iced tea or Coca-Cola, he's probably spilling myoglobin, and we need to treat that. So along with that lactic acid and the myoglobin, that destruction of cells also causes the leak of large amounts of potassium in the body. Get it? Not okay. K plus potassium. All right, sorry, dad jokes. So that leak of potassium, that potassium level after a crush injury usually peaks around 12 hours after the initial injury. So how do we restore balance? Well, sorry, it still says it. So it's actually not that hard from a first line perspective. If we realize all these things, the lactic acid, the myoglobin, the potassium, they're all spilling into the bloodstream, just like with rhabdo, we got to flush them out. Get the IVs going, get the fluids running wide open. These patients need several liters of fluids just to begin to restore balance. With the fluids up, you can then go about correcting their acidosis or the hyperkalemia with any other methods in addition to the fluid resuscitation. So you're in the trauma bay and a guy comes in with a suspected crush injury. What do? Well, you got to use what you got. So look at your patient, right? Use your eyes. Does he have any visible signs of a crush? And by that, I mean, does it look like any part of his body is more squished than it should be? Use your ears, guys. If your guy is screaming in pain, even though you don't see too many visible injuries, you got to wonder, is this compartment syndrome? Is his pain out of proportion to his suspected injury? And use your brain, guys. This is where we actually have to think a little. Look at the vital signs. Look at his skin. Is he showing signs of shock? We now know the signs of compartment syndrome. Do you notice any? Look at his urine. Check his mental status. Do you think he's going into rhabdo? This is where we start putting together really fast puzzles as we stand in the trauma bay. And, of course, while we may suspect all of these things, we need our labs. We need that CMP, the ABGs, and we need them quick. So, treatments for crush. We talked about this a little bit. Fluids. I think we talked about fluids a lot because we need a lot of them, like really, bag after bag. If they're bleeding, stop the bleeding. This is trauma 101, guys. If there's a wound that looks dirty, like if there's grass or gravel or dirt in it, try to clean it out gently. Okay, this is not the time for scrubbing wounds. This is also not the time to pull out your tweezers and start removing each individual little piece of dust. But grab a few saline flushes, try to flush out what you can. If there's a giant piece of glass, maybe you take that out. And like I said, get those labs, check your compartment pressures, and if the diagnosis is confirmed for a compartment syndrome, prep them for a fasciotomy, which of course is going to lead to the OR. So a couple of concepts here, guys. We talked a lot about lactic acid and potassium and myoglobin. It's important with crush injuries to remember your acid-base balances and your fluid and electrolyte values. And of course, as with any trauma, we got to have that solid foundation of anatomy in order to think of any of the injuries we really can't see. So some key points I want you to remember. Remember your signs and symptoms and learn to recognize the evidence of that even larger problem than what you see, all right? Let it flow. We talked about fluids. Get them up, get them open wide, and keep giving them. Keep it level, guys. If we suspect that compartment pressure, keep the limb at the level of the heart. Not above, not below, at the level. We got to get those labs. The only way to kind of monitor their acid-base balance is if we actually have their acid-base balance in our hands. Get the labs, get them early, get them often. We want to trend that. And as always, talk to your patient. How are you going to know his level of consciousness if you're not actually asking him questions? What he says may be really significant in coming up with a diagnosis. Thanks again, guys, for joining me. Keep an eye out for more lessons on emergency medicine and trauma. And as always, happy nursing.